Good morning, everybody. I would like to present on behalf of the Pelvic Floor Disorders Network our multi-center randomized trial of sacral neuromodulation, or InterStim, versus Botox for refractory overactive bladder. I have no disclosures. Our target audience were women with urgency urinary incontinence refractory to medical therapy. There is insufficient evidence in the literature to decide between InterStim versus Botox therapy. Our objective was to compare the efficacy and safety of 200 units of Botox with InterStim therapy over a 6-month period of time in women with refractory urgency urinary incontinence. We enrolled women with equal to or greater than 6 urgency urinary incontinent episodes on a 3-day bladder diary. They were randomized to either in-office injection of one-time dose of 200 units of Botox or a staged InterStim procedure in the operating room. These women were then followed with monthly 3-day bladder diaries over a 6-month period of time. Our primary outcome was the change from baseline in the mean number of daily urgency urinary incontinent episodes over 6 months using 3-day bladder diaries administered monthly. Secondary outcomes of interest included the percentage with complete resolution of UUI episodes, as well as those with a greater than 75% reduction in UUI episodes and a greater than or equal to 50% reduction. Other bladder diary parameters, such as voided frequency, nocturia, episodes of stress incontinence, and pad usage, were also collected. There were several quality of life measures that were recorded and evaluated. We captured adverse events, including the proportion of those who received Botox therapy who required intermittent catheterization. Our definition of those who required intermittent catheterization were those that had a greater than or equal to 200 cc post-void residual with bothersome voiding symptoms, or those that had greater than or equal to 300 cc post-void residual. We also collected the proportion of those that required a revision or removal of the InterStim device. Lastly, we collected the proportion in each group who were treated for a urinary tract infection. We consented 480 women, 386 were randomized, 364 women were available for primary outcome analysis in the intention to treat population. 190 were in the Botox arm, and 174 completed the InterStim arm. We defined clinical responder population as those that had a greater or equal to 50% reduction in the mean urgency urinary incontinent episodes on a 3-day bladder diary. This was assessed for the InterStim population during the test phase or stage 1 procedure, and for the Botox population 1 month after their 200-unit injection. Of the 192 women who were randomized to Botox, 83% were categorized as a clinical responder. Of the 189 women randomized to InterStim, 84% were categorized as clinical responders. As one would expect from a randomized trial, there were no clinically meaningful differences in clinical or demographic parameters. I highlight, however, that over 80% of our study population had severe or very severe incontinence based on the Sandvik questionnaire. Our primary outcome of the reduction of mean daily UUI episodes of over 6 months revealed that Botox group had a greater reduction in these episodes in the intention to treat population. Similar findings were seen in the clinical responder population. Complete resolution of urgency urinary incontinence episodes was over 5 times as likely to occur in the Botox group than the interstim population. And Botox participants were twice as likely to have a greater or equal to 75% reduction in their urgency urinary incontinence episodes than the interstim population. Both groups did have a significant reduction or improvement of their OAB symptom bother scores. However, again, the Botox population saw a statistically significant difference in their improvement. They also had a higher percentage of treatment satisfaction as well as endorsement of their treatment. But there are no other quality of life parameters that were shown to be different between the two groups. Through 6 months, the Botox participants did experience a higher percentage of urinary tract infections than the interstim group. There were 3% of the interstim population that required a surgical removal or revision. In those requiring intermittent catheterization, it was 8% at 1 month with Botox, and at 6 months, it was 2%. So in conclusion, in the study population, we found that compared to interstim, a single 200 units of Botox provided greater reduction in urgency urinary incontinence at 6 months, higher likelihood of complete urgency incontinence resolution, greater symptom bother improvements, greater reduction or greater treatment satisfaction and endorsement, albeit an increased risk of UTI that was a need for transient catheterization. Thank you.
Thank you very much. Now the abstract is open for question. I see already.
You're standing there.
Peter.
Hi, good morning. Peter was here from Utrecht, the Netherlands. Congratulations with such an achievement and such an endeavor to do this and organize this. What you did also very good is publish your protocol and the rationale almost before you started the protocol. And what I read in that publication is that you recruited patients and also did urodynamics, and that you included patients without the overactive detrusor on urodynamics. And now my question, in all the manuals and teaching books and every definition that I'm aware of, is that patients with urinary incontinence without overactive detrusor have stress urinary incontinence. And there's no mechanism of action in both of your trial arms. My question, how could you have recruited those patients for that treatment? And the other question is, has that affected the overall outcome of your trial, which has an overall not extremely high rate of success?
Okay. To understand your question, we did have about 58% to 68% in each two arms that did have detrusor overactivity demonstrated on urodynamics. So there was a percentage of patients who did not have detrusor overactivity on urodynamics. However, we had a very low percentage, less than 5% of the population admitting to stress incontinence symptoms. So we did have a very, at least clinically relevant group that had overactive bladder symptoms that were either documented on urodynamics or on a bladder diary. So I think this treatment was really directed at a population with urgency urinary incontinence.
Next question.
Yeah, Ken Peters from Beaumont Hospital in Michigan. Cindy, thank you it was a great presentation. So I just, a little bit of clarification for me, because I think when we present something like this, we need to have some understanding of the background, because the two are not equal, and InterStim is kind of a work in progress, and Botox is a single injection. So I guess my questions would be, you know, those who implanted these patients, what was their experience before being part of this trial? Were they high-level implanters, or were they fresh? Second is, you know, do we have data on the voltages that we use? So that would be a kind of a surrogate to how well the implant was placed. We didn't talk at all about reprogramming episodes and timing of that when your endpoints were, because all of these are really important in the management of neuromodulation. And when you talk about intent to treat, so you had in the InterStim group 16 dropped out and Botox 4. How was that data handled then? Those 16 that dropped out, is it just last value carried forward? Is it their baseline carried forward, or were they excluded from the analysis? Sorry, that was a lot of questions.
That's okay, Ken. I think I did follow you on all these, on your questions. The first one is we did have a very structured protocol with regards to the number of implants and who was implanting. The pelvic floor network does a lot of surgical trials, and we have found that surgical procedures, minimum of 10 procedures, have to have been done by those that are either doing the surgical procedure or the Botox injection, and they had to be continuing implanters, you know, in their practice. So we did really have a group that were implanting all the time. Not everybody in the network did implant InterStim because they weren't implanters. So we did, each site had their highest implanter implant the device. The protocol also gave very strict criteria for implanting in the time in the operating room. There was criteria for the number of electrodes that had to be have positive motor and sensory responses, and the voltages had to be below a certain threshold. I think what was, you know, reflective was the high clinical responder rate that we had, which was 84% of the population in InterStim and 83 in Botox were deemed clinical responders. So that is a reflection of how good the implant you know, how good it occurred in the operating room and how successful it was, and with the low revision and removal rate that we had, which is comparable to the literature at 3% at 6 months. Yeah, subsequent paper will be coming out looking at risk factors for failures and successes, and we'll look at reprogramming needs. But throughout the time period, the PGI was assessed as a score whether or not a patient then needed to be reprogrammed when they came back. So if they had dropped down on their PGI, then they were reprogrammed, or, you know, and so reprograms occurred throughout the entire time of the 6 months. We also decided to collect bladder diary information over 6 months as opposed to one fixed bladder diary, because we knew that both therapies could have this fluctuation of results in an isolated bladder diary. So that's what we took into the equation.
Sorry, we are running out of time, so if I can ask
Ken, I'll speak to you in
pose
the back.
shorter questions and allowing shorter answers as well. But no, I think we have time for the last question. Short,
Okay,
please.
I'll be very short. Magdi Hassuna, University of Toronto, Canada. One question to you: what do you see this as a long-term application? Because you tackled a very delicate issue comparing the two apple and oranges. We have seen that on the 5-year mathematical model, the InterStim fares much, much better. But still, you're just showing results of 6 months. 6 months is a very, very, very short time to get any results. Do you have any data on the long run?
Yeah. Good question. Unfortunately, the study has continued to 2-year outcomes, so we will have 2-year data. Reinjections will occur after 6 months to that 24-month outcome. We'll also have cost analysis, real-time cost analysis between these two, at least at 2-year outcomes.